Well, good evening, everyone. Thank you for being here. Dr. Parekh, thank you for the opportunity to present. I'm going to get right to it. These are my disclosures. Drug-coated balloons. Today, I'll be primarily focusing on paclitaxel. That's the one that we have the most robust data on. It's also the one that's been around the longest and the one we have available in the US. The sirolimus balloon is probably coming to the US as well. It's been available in Europe for years, but for purposes of this talk, paclitaxel is what we're going to focus on. And just to make it clear, this is not a new technology. The first use in a human was in 2003 as part of an investigational trial. First commercial paclitaxel DCB was made available in Europe in 2009. Here in the US, it was 2024 when we got the approval, very late if you ask me. And even to this day, there are major hospitals here in Houston, high volume hospitals, that still do not have this technology on the shelf, which is obviously not good, and we need to change that. Anytime a new technology comes out, the first question is always, is it safe? As some of you may recall, there was a meta-analysis in 2018 in PAD literature that showed a late mortality signal with paclitaxel-coated balloons. That was ultimately debunked with real-world data, and eventually, in 2023, FDA concluded that there is no increase in mortality with paclitaxel use. This was just one study, a meta-analysis that was published in 2020 that showed actually reduced all-cause death, cardiac death, and myocardial infarction was paclitaxel DCB compared to DES or BMS. The next study we should talk about is the Daedalus. This was a meta-analysis, 10 randomized clinical trials. They basically had nearly 2,000 patients, and at 3 years, their primary safety endpoint of all-cause death, myocardial infarction, target lesion thrombosis was comparable between DCB and DES in treatment of ISR. However, if you look at ischemia-driven target revascularization, it appeared that DES was superior to DCB. Now, if you look at this in more detail, you'll actually see that that signal is only prevalent for DES ISR. For BMS, that was not the case. Nonetheless, this did eventually lead to change in the ESC guidelines. So in 2024, DES is recommended over drug-coated balloon for treatment of in-DES restenosis, and that's class 1, level of evidence A. That's a change from 2018 when both DCB and DES had class 1 indication for treatment of ISR without distinguishing between BMS ISR and DES ISR, which, the two are probably very different processes. Agent ID was the pivotal US trial. It was prospective randomized, 40 US sites, 600 patients. Inclusion criteria were lesion length less than 26 millimeters, vessel diameter greater than 2, less than 4. And they obviously all had ISR, and the key exclusion criteria were STEMI, bifurcations, and grafts. So 406 received the agent DCB, 194 received POBA, and at 1 year you can see that target lesion failure was far superior with paclitaxel DCB, so was ischemia-driven target lesion revascularization as well as target vessel-related myocardial infarction. There is no difference in cardiac death. So this led to the approval of the agent DCB, which hopefully all of you have on shelf now. This was another meta-analysis, almost 4,000 patients, 18 randomized trials, comparing DCB to DES to POBA in treatment of ISR. Now, as you can see here, both DCB and DES were markedly superior to plain POBA. They lowered MACE, primarily driven by lower TLR. However, on top of that, when you look at DCB, it was also associated with a lower late lumen loss, with no significant excess in any clinical outcomes, even when compared with drug-eluting stents. So that's another thing that goes to show you that this technology is probably superior. And just to talk about what that means, so anytime you have a patient with ISR, you perform a PCI. If you implant a stent, the gain you get in that lumen is your acute gain. Now, as time goes on, you always suffer a late loss. You bring them back 6 months, 12 months later, let's say, or they end up in the lab for a different reason, you do an angiogram, your lumen will be smaller. And that's the late loss that you suffer. With DES implantation for ISR, you get a bit bigger acute gain. However, you also suffer a greater late loss. And what ultimately matters is your net gain. What DCBs can do for you in this situation is, even though your acute gain may be lower, as you know, compared to when you implant a stent, you also suffer a much smaller late loss. And in fact, if you look at DCB for de novo coronary disease, there is a significant increase in your lumen area later on, meaning you actually achieve a late lumen gain in about 40% of patients. So what is my approach to choosing DCB versus drug-eluting stent for ISR? I favor DCB whenever there's multiple stent layers. I try to avoid a third layer of metal. High bleeding risk patient where I want short depth, I prefer a DCB. Underexpanded stent or focal ISR, I think DCB is superior for that, and BMS ISR per Daedalus study that I showed earlier. I favor drug-eluting stent whenever there's single layer of DES, especially if the reference vessel diameter is greater than 2.75. If I see heavy calcification that needs scaffolding, obviously I will favor DES for that. And long segment ISR in a large vessel, I favor DES. I also favor DES for DES ISR. However, if the vessel is 2.5, I probably would still choose a DCB. The most important thing whenever you're dealing with ISR is you have to define the cause. You have to image if there is any underexpansion. You have to make sure that you prep this lesion appropriately and you correct the underlying problem. You have to make sure your MSA is at least 80% of your distal reference, if not bigger. And then once you do all that, you make sure you have optimal lesion preparation. If you have TIMI 3 flow, residual stenosis of 30% or less, and no major dissection, then you can go ahead and use your DCB and you will probably get a very good result. So with that being said, we can get to our first case. This is a 64-year-old gentleman that has ESRD. He's on dialysis, multi-vessel CAD, multiple PCIs in the past to his circumflex and his RCA. Also had a robotic lemur after that, and he has a normal EF. I saw him in clinic for crescendo angina. 3 months prior to this, he was admitted to an outside hospital where he underwent a PCI for a circumflex STEMI. And just reading through the notes, it seems like it was the third stent that was placed in that territory. So we took him to the lab. His lima was open. His RCA is a known CTO, so likely not the cause of his symptoms. His circ has multiple layers of stent, essentially 2 layers throughout, and there is a spot with 3 stents in there, which you can see a little bit better here, which clearly look underexpanded on the angiogram. So as we always do for these cases, and I'll try to spare you the full imaging run, but we performed imaging, and as you can see here, he has 3 layers of stent all inside each other, underexpanded, was a MLA of 2.2. Severely underexpanded, 3 layers of stent, all cramped into each other. So whoever did this PCI where they put a third stent into an underexpanded stent probably did not do this gentleman a favor. So we knew we had to correct this. I went with an NC balloon. That did not yield. Ended up using an IVL balloon, which ended up yielding. And after that, I implanted a 4.0 by 40 peripheral DCB here. You can ask me, why did you use a peripheral DCB? Well, this case I did 2 years ago, and we did not have a coronary DCB on shelf. And then I added a proximal stent where he only had 1 layer stent. I did not implant anything distally because he already had 2 layers in there. And this was our final result. And just to compare your OCT imaging, this was the pre and this was that same area post. So you can see the lumen area is now 6.74. It's expanded, and this gentleman actually ended up doing well. He actually has not had any events since then. These 2 I want to show as an example of where I would still choose DES even though I could have used DCB. This is a 61-year-old man. He has hypertension, hyperlipidemia, coronary disease, had a prior PCI in 2013, was a drug-eluting stent. Presents with exertional chest pain, had an angiogram, was one of my partners at a different... Okay.
They're coming.
I'm almost done. So as you can see here, he has severe ISR in his circumflex. So what my partner did was he ballooned, this was an NC balloon, he used an IVL balloon, but even after that, he still had a significant waste. So he did the right thing, he stopped, and he referred him to the medical center for a PCI of his circumflex, balloon undilatable lesion. And as always, we image first. And as you can see here, he has some dissections from the prior angioplasty. The stent itself looks good. The main problem he has is he has severe neoatherosclerosis inside of that stent. He has built a lot of calcium inside of it, and that's essentially the main reason why this is not expanding. So I had to choose between using the Rhoda or the laser. I went with the 1.4 laser with contrast. I typically like to use half and half for these. I think it's a little safer. After I did that, I used an OPN balloon. The lesion ended up yielding at 36 atmospheres. And after that, I chose to implant a stent. Now, the reason why I decided to go with a drug-eluting stent in this case is because this is a pretty large vessel. It's a drug-eluting stent ISR, and per Daedalus, again, you should probably re-stent this. And it's heavily calcified. So all those were kind of the reasons why I wanted to go with that. I put a 3.5 by 38 drug-eluting stent, post-dilated with a 3.75 balloon, and then I'll spare you the full imaging run, but this is my angio. It looks pretty good. And then last, I want to talk about de novo DCB. I personally think that 5 years down the road, de novo DCB, meaning DCB for non-ISR coronary disease, is going to be 80, if not 90% of all our DCB use. Areas where I find it extremely helpful are bifurcation PCI, small vessel, especially when it's less than 2.5, your select STEMI and STEMI anatomy. Let's say you have a young patient comes in with a osteoramus STEMI, you balloon it, you have TIMI3 flow, there's a little bit of a residual lesion, you don't want to stent obviously from the ramus into the left main, it's a great option. And then your CTOs, whether you want to stent the CTO segment, DCB the distal disease, or DCB the whole thing, bring it back, I think it's a fantastic option for that. And then your high bleeding risk patient. But before you go into that, you have to ask yourself, what is considered an acceptable angioplasty result? And you have to have TIMI3 flow, that's non-negotiable. Your residual stenosis should be 30% or less, no chest pain, no ST changes, and uncomplicated dissections only. What do I mean by that? Your A's are fine, your B's are fine. Your stable C is fine as long as the contrast is not persisting there for more than 20, 30 seconds. You're probably fine to go ahead and use a DCB. But if you get into more complicated dissections or loss of flow, obviously you have to convert to stenting. So the next case, last case, 73, new onset angina. He's on some anti-anginals. His prior Agatston score was 1700, normal. And given his calcium burden and angina.
They cut you off, Javid. I saw the last patient left the Kelsey Insurance and came to see me a couple of weeks ago. Had complete occlusion of that. No, I'm just kidding. No, please let him finish, please.
Wow. You didn't cut anyone else off, man. I'm the only one? I thought we were friends.
I've been waiting all year for this.
Anyhow, so his anatomy, his main problem is he has severe Medina 111 LAD diag right here. This is the main problem. So we discussed it with our heart team. There was equipoise between CABG and PCI. We decided to go with PCI. Right radial, I'll spare you the full IVUS run again, but essentially very heavily calcified. LAD reference was 3.0 distally, 3.5 proximally, diagonal was 2.5. So use the cutting balloon on the LAD and then use the scoring balloon on the diagonal. My algorithm for this is typically I will treat both branches, the main branch and the side branch. After I do that, I do an angiogram. And what I'm looking for here is my diag, I want to make sure I don't see any major dissections, TIMI3 flow, no ST changes, no chest pain. And he met all those criteria. So because of that, I used the 2.5 by 20 agent balloon on that diagonal. After that, I implanted my LAD stent and did a pot, and this was our final result. And, looked pretty good. His angina went away.
He's 20 again. Dr. Pasalian, Milad, Robert.